Good evening, everybody. My name is Jenny Pearson. I'm an Education Officer for the Primary Health Network. Welcome to our webinar tonight, Deprescribing Psychotropics. Before we go any further, I would like to acknowledge the traditional custodians of the lands we walk, reside and work upon. We pay our respects to First Nations people and value the continued connection to culture, country, waterways and contributions made to the life of our vast region. I'm coming to you from Enewan land in the beautiful Northern Tablelands in Armidale. Tonight we have Dr. Mark Harrowitz with us from the UK. So fingers crossed the internet gods are on our side. We have Sandra Fitzgerald from Health Pathways, and we have Dr. Terry Parkin, who's a GP and is going to facilitate our Q&A session. All our questions will be answered at the end of Mark's talk, because often people will ask a question and then partway through the talk he'll have the answer that's going to be in the presentation. So we'll wait until the end. Sandra will then do a quick update on Health Pathways on this topic. I think that's about all that you need to hear from me. Please type your questions in so that Terry can read them out and answer them at the end. This webinar is being recorded and it will be uploaded to our library tomorrow. I think that's all you need to hear from me, so I will hand over to Mark.
Great. So thanks very much for organising this. I'll just say, although I work in the UK, I'm an Aussie originally. I grew up in Sydney. I'm a training psychiatrist and a researcher. Did my PhD in the UK, and a lot of my work has been on how to safely stop psychiatric drugs. And I contributed to the NICE guidelines in the UK, and I wrote the guidance for the Royal College of Psychiatrists on how to stop antidepressants. And more recently, we put together a textbook, a clinical handbook, the Maudsley Deprescribing Guidelines, and a lot of what I'm talking about today is in that book. And at the end of my talk, I'll give you a QR code so you can download a free copy of it, which is made available through the Royal College of General Practice, which has endorsed the book, and I can see that your health pathways has been updated with guidance now from that book, which is great to see. So I'm going to actually, I might start by showing a video that was made by some Australians who have come off antidepressants and wanted to communicate to GPs what the experience can be like for some people. So I'm going to share my screen and people will tell me if this works and you can hear it, please.
Why were you first prescribed an antidepressant?
I was prescribed when I was 22 and I had just had a relationship breakup.
I was prescribed an antidepressant in 2013 for a chronic pain condition called trigeminal neuralgia.
I was first prescribed an antidepressant because I was going through some dark times in life. I had an ACL reconstruction on my left knee and I was going through school at that time.
How did the antidepressant make you feel?
I felt like I was just like a robot. I was very emotionally numb.
I still had the anxiety, but it was numbed down. But unfortunately, not only did it numb down my anxiety, it numbed down my emotions. You know, I couldn't feel any intense happiness or sadness anymore. I lost the ability to cry.
I put on a lot of weight. I completely lost my libido. And I just found myself incredibly tired.
When I was first put on these drugs, I thought it was fantastic because it quieted my mind and numbed me, but I didn't know the trap I was digging for myself.
What has your experience been when you came off or reduced the dose of the antidepressant?
My brain felt like it was burning and splitting, but everywhere, along with pains and washing feelings I can't describe. I was forcing myself to eat. I lost around 14 kilos. My clothes became really baggy. I had diarrhea I couldn't stop. I was super sensitive to light and sound, even hot and cold.
All hell broke loose. I have never experienced the terror, the extreme physical and mental upheaval that I went through.
I experienced my first major depressive episode like nothing I'd ever experienced before in my life, but I just thought it was me. It was much worse than any low mood I had previously felt during my first 27 years and before being prescribed an antidepressant.
I became sensitive to noise. I was fearful of people visiting. I couldn't watch the television. I couldn't read a book.
And I experienced akathisia for the first time ever, which is actually quite difficult to even describe, but it feels like an extreme panic attack combined with just explosive feelings of pressure in your brain and your entire body.
I had intense anxiety, intrusive, dark, looping thoughts. I developed akathisia and paced around the house so uncomfortable in my own body. I wanted to rip my skin off.
Dizziness, and also these sort of zappy electric kind of sensations that I've heard called brain zaps. They didn't worry me so much as the emotional, psychological tsunami that then hit me.
Inability to function, struggling to walk in a straight line. That doesn't, I could go on and on. Yeah, just struggling to stay alive.
How has antidepressant withdrawal impacted your life as a whole?
It has pretty much destroyed my life. It's traumatized myself and my family and caused extreme distress.
And one of really the worst thing that's been for us is the isolation in regard to medical professionals. They just do not understand the severity of withdrawal symptoms. It was just terrible visiting doctors and realizing they had absolutely no idea about this experience.
Friendships have been affected. People just can't comprehend how a prescribed medication can cause so much harm. I've lost years of employment as a direct result of antidepressant withdrawal.
It's hard to think of an area of life that it hasn't impacted. Obviously, it had a massive impact on my family, massive impact on my sense of well-being. I mean, it's an experience that I just wouldn't wish on anybody.
Taken everything from me, taken my job, my ability to work, took my partner off me. It's taken everything from me.
What did you need from health services that you did not receive?
I needed health services to know about this. I needed them to know what I tried telling them was real, so they could help me, or at least be understanding and not dismiss me.
I needed to be treated with more empathy and compassion. I was often treated as a non-compliant, difficult patient who couldn't accept the reality of her condition.
That last doctor, when I tried to talk to him about what was going on, would have been able to see through my tears and been able to differentiate the symptoms of withdrawal from relapse.
I really needed acknowledgement and validation that what I was experiencing was real. I also needed a safe place to go where I had no fear of being sectioned or drugged up to manage my symptoms.
They denied the possibility of withdrawal with such conviction that I left every appointment feeling like a crazy person. And their lack of understanding made me feel like I was the problem.
I'll stop sharing this and go back to my slides. And what I want to talk about is to make sense of what those patients expressed and why it's so different to what has been in guidelines for so long. So again, tell me if I've successfully sharing my slides here. I guess the first thing to say is the context for this. In Australia, 1 in 7 people, that is 1 in 6 adults, are currently on an antidepressant. It's now about 3.9 million people each year, and it's doubling about every 10 years. The average duration of use is 4 years. Most guidelines recommend 6 to 12 months use for an episode of anxiety or depression. I don't know if Australia can be called the lucky country anymore because it is amongst the highest users of antidepressants in the developed world. In fact, 2 antidepressants are now in the top 10 most prescribed drugs in Australia. Women are prescribed the drugs more than men, older people more than younger people, and there is more prescriptions given out in poorer inner regional areas than in urban centres, and all of this has led people to suggest that deprivation is being medicated in lots of circumstances. The guidelines, places like the therapeutic guidelines, guidelines from the Royal College of Psychiatrists have said for years that discontinuation symptoms from antidepressants are usually mild and last a week or two. And this description comes from papers produced by the drug manufacturers in the 1990s, which focused on people who had been on these drugs for 8 to 12 weeks. And it is true that most of those patients did have mild and brief symptoms, not all of them, but most of them. But as we'll see, the longer you're on antidepressants, like the years that lots of Australians use them for, the harder it is to stop, the more severe withdrawal symptoms are, and the longer lasting they are. To me, it's a little bit like a car company crashing a car into a wall at 5 kilometers an hour for a safety test and saying it's safe, and ignoring the fact that most people are driving around on the roads at 60 kilometers an hour. There was a consensus panel organized by drug manufacturers where the euphemism discontinuation symptoms was coined, which doesn't have any scientific meaning. It was designed to limit negative press for their product, and it became normalized by publication in many papers, along with this description, brief and mild. And along with this, places like the therapeutic guidelines have said and still suggest that the way to reduce antidepressants is to quarter or halve them every couple of weeks until you get down to half the lowest tablet available, continue for another couple of weeks and then stop. This guidance is not based on any research evidence. It's based on the fact that a single study in which drugs were stopped abruptly produced withdrawal effects for most patients. And so the committee at the time decided that 4 weeks was a reasonable time to stop these drugs over, on the premise that withdrawal effects were brief and mild. And so it makes a lot of sense for short-term users and much less sense for longer-term users. We know that most doctors are following these guidelines. They stop medications over 2 or 4 weeks. There was a recent trial in the UK that tested this in a very low-risk group of patients and found that most of them could not come off their antidepressants in this way, which means that a lot of people in Australia are trapped on their medications with the current approach to coming off these drugs. One of the consequences of this is people leave the health system and go to online peer support forums to get advice on how to come off antidepressants and other psychiatric drugs. These are 2 examples of websites. They get 1 million hits a month. 6% of that traffic is from Australian patients. The commonest story is, I was told to stop taking my antidepressant or other psychiatric drug over a few weeks. The effects were so horrendous, I ended up in hospital or had to go back on them. The doctor told me there shouldn't be a problem with coming off, so it must be my original condition coming back, diagnosed me with relapse, and told me I may need to be on this drug lifelong. But it felt different to my original condition. I was dizzy, I had brain zaps, these little electric shock sensations that people get in their heads, or I had panic attacks for the first time in my life. So I've lost faith in my doctor, and the advice on this website was much more helpful. And what these websites generally recommend is to come down at about 10% of your most recent dose each month. So when you're on 100 milligrams of a drug, to reduce by 10 milligrams that month. When you get down to 90, go down by 9 milligrams. When you get down to 20 milligrams, go down by 2 milligrams a month. And it can take people months and sometimes years to come off. And they say that doing it that way makes the process much easier, although still not a walk in the park. We surveyed more than 1,000 people who have used such websites. They said they were there because they found their doctor's advice unhelpful for the following reasons. Doctor recommended too fast a rate of reduction. they weren't familiar enough with withdrawal symptoms to advise me, or they said that stopping antidepressants would not cause withdrawal symptoms. Most people were told to stop over a few weeks. And what people wanted was two main things. One, access to smaller doses to make these more gradual reductions that couldn't be done with existing tablets or capsules. They wanted things like liquid versions of the drug or compounded tablets, capsules or liquids, and they wanted a health professional that understood how to oversee a personalized, flexible, gradual hyperbolic taper that we'll talk more about in a few slides. This is the only neurobiology slide I'm going to torment you with. I'll do it briefly. This is two nerve cells meeting with a serotonin synapse in between them. Serotonin is released into the synapse and it affects receptors for serotonin on the second nerve cell. And this is the serotonin transporter that sucks serotonin back into the first nerve cell. When you introduce an antidepressant, it blocks this plug, so you get more serotonin building up in the synapse. It's the equivalent of putting on the accelerator on a car. You now have a lot more serotonin here, which means that these serotonin receptors are now being bombarded with more serotonin than they're used to. And because of the principle of homeostasis, that is, we like to stay in the middle. When it's too hot outside, we sweat. When it's too cold outside, we shiver. The body reduces the number and sensitivity of these receptors. You can see that on neuroimaging after just a few weeks on an antidepressant. In other words, the body has put the brake on to balance the accelerator. When you come to stop the drugs, it's metabolized from the system by the liver and kidneys in a few days or weeks, and the plug is unblocked, and you go back to having normal levels of serotonin in the synapse. But what doesn't just snap back into how it was before the drug was there is the brake. We can see from imaging studies that people that have been on long-term antidepressants can have changes to their serotonin system that last for up to 4 years after the drug is stopped. And so now what you have is normal levels of serotonin, but reduced number of receptors. And that probably is what explains withdrawal effects. You now have a sort of low serotonin signaling system. There's, of course, other receptors affected. There are things that are downstream. This also helps to explain why withdrawal effects can last so long. So what often happens is a patient will come in and say, I stopped my antidepressants 6 months ago, and I'm still having headaches, dizziness, brain zaps, panic attacks. And the doctor will say, that can't have anything to do with your drugs because they're out of your system after a few days or weeks. It must be a mental illness or another physical health problem. But that's based on a misunderstanding of what causes withdrawal effects. It's not the time taken for the drug to leave the system that explains how long they last for. It's the time taken for the brake to be taken off. In other words, for these receptors that have been adapted to the drug, for them to go back to their normal state, their, if you will, their factory settings. We also know from animal studies that these changes can last for more than a year. They can affect hormones and the serotonin system. I'll give you a quick analogy. If you go into a loud concert, your eardrums become less sensitive to sound. And if you walk into the quiet street afterwards, your friends' voices sound muffled for a minute or two. It's actually a sound withdrawal syndrome. The reason it takes a minute or two for your friends' voices to sound normal is because that's how long it takes your eardrum to relax, even though it only takes a second for the sound to dissipate when you close the door on the concert. In other words, it's the time taken for the adaptations in your brain or eardrum to dissipate, and not the time taken for the stimulus, like sound or the drug, to dissipate from the system. And that's why people can have these long-lasting, protracted withdrawal syndromes. So antidepressant withdrawal symptoms are a physiological set of symptoms that occur on stopping or reducing the dose of an antidepressant. They can manifest in either psychological or physical symptoms because these drugs affect so many bodily systems. They occur because changes, adaptation to the brain caused by the drug take time to resolve, as I've just shown you. Another misconception is that withdrawal implies addiction. That's not the case. Things like compulsion, craving, the essence of addiction isn't relevant to antidepressants because they're not reinforcing enough. But all you need for withdrawal is adaptation to a drug. In pharmacology, that's called physical dependence, although unfortunately that term has become conflated with addiction in some usage. I'll give you an example. I would guess that most of the audience is physically dependent on caffeine. You're using it every day. If you were to stop it, you'd get a withdrawal syndrome, not a particularly severe one. And I'm also going to guess that nobody in the audience is injecting caffeine or stealing from their neighbors to get more caffeine because no one is addicted. But all you need for a withdrawal syndrome is physical dependence or adaptation, as for antidepressants. And the flip side of withdrawal effects from antidepressants is tolerance. So definitely over long-term use, people become more and more tolerant to their drugs, although this is often minimized by the manufacturers. In America, our colorful colleagues call this poop out of their drugs. There is a very long list of withdrawal effects from antidepressants, of which this is just a selected group. Because the drugs affect so many bodily systems, people get dizziness, insomnia, impaired concentration, fatigue, headache, tremor, tachycardia, nightmares. People can even get arrhythmias in coming off these drugs. There are mood symptoms, depressed mood, anxiety, irritability, panic attacks, obsessional thinking. We know that these are withdrawal effects and not just a return of people's underlying condition, because even in studies where people don't have an underlying mental health condition, where they have pain or the menopause, or even in healthy volunteers, you can still see these symptoms occur on stopping the drugs. There are the sensory symptoms that I've mentioned. People can get burning in their skin or all sorts of funny neurological symptoms. There are lots of gut symptoms because there's a lot of serotonergic neurons in the gut. There's an increase in suicide attempts in the weeks after stopping an antidepressant, even in people who have never been suicidal before, which has been attributed to withdrawal effects directly. And then another issue, a very important one mentioned by a few of the people in that video montage, is akathisia, which might be unfamiliar to some people. It comes from the Greek word for can't sit still. It's more well known as a side effect of long-term antipsychotic use, but it can also occur in withdrawal from antidepressants or other psychiatric drugs, and these are the sickest patients that I see. They are often pacing, agitated, say they feel a sense of terror. I've heard people describe it as feeling like their nervous system is on fire, and because this set of symptoms can go on week after week and even month after month, people find it so unpleasant there's a high risk of suicide. Because this is not well recognized, when people turn up to the emergency department, they are often misdiagnosed as having a mental illness, agitated depression, or mania, rather than a withdrawal effect from their drugs. Another very common misdiagnosis is withdrawal being misdiagnosed as a relapse of an underlying condition. It's the main reason why people leave mainstream health. It's very easy to understand why that would happen. After decades of guidelines saying that withdrawal effects are mild and brief, when someone turns up to a clinic with severe or long-lasting symptoms, it's easy to flash on relapse, not withdrawal, especially when many withdrawal symptoms overlap with the symptoms of an underlying health condition. There are a few clues to help distinguish withdrawal from relapse. Withdrawal tends to have a quicker onset, a few days, but it also can be delayed by weeks, probably because it takes downstream effects time to build up, which can be very confusing for clinicians and for patients. There are specific symptoms in withdrawal, things like brain zaps, dizziness, which are not typically a part of anxiety or depression, but the most common symptoms of withdrawal are psychological symptoms. Sometimes the patient will tell you the diagnosis. They will say, I have never felt this way before, or this is much more severe than I have felt in the past. It's always very useful to know what people's baseline symptoms were. So if they went on a drug a few years ago when they were depressed, they were lethargic, they were sleeping many hours a night after the death of their mother, and now they've come off their drugs a few years later and they're anxious, they're panicked, they can't sleep, it's much more likely that they've developed quite common withdrawal symptoms than coincidentally just at the moment they've come off a drug, developed a new onset panic disorder, although many clinicians unfamiliar with these symptoms will often make that sort of misdiagnosis. If antidepressants are restarted soon after withdrawal effects start, then there's often quick resolution. If there's a delay, things become much more unpredictable. And other misdiagnoses that can be made are things like chronic fatigue syndrome, medically unexplained symptoms, and a variety of neurological and psychiatric disorders because the symptoms of withdrawal overlap with the diagnostic criteria of many of these conditions. So how many people are we talking about here? Is this an exception? Is this a very small group of people? How common, severe, and long-lasting are withdrawal symptoms in general? There are a variety of reviews out now about this. The main factor underlying this is how long someone's been on the drug for. So this is summarized in the graph on the right. This is a very simple study where people were asked, how long were you on an antidepressant before you stopped? Did you have any withdrawal symptoms when you stopped? That's the top line. And were those symptoms moderately severe or severe? That's the bottom line. And you can see that for short-term users on it for a couple of months, only a third of people have withdrawal effects, and most of them say it's mild, only less than 20% say it's moderately severe or severe. Whereas once you've been on the drugs for 3 or 4 years, like the average Australian, most people are having withdrawal effects, and half of them are saying that they're moderately severe or severe. This is where the drug company studies were done, down the bottom, and as I said, it's not as informative for people that have been on the drugs for a much longer period of time. And that's the group, of course, that has the greatest risk. I think there is greater recognition that when people stop antidepressants, there are withdrawal effects like headache and dizziness. I think that's part of the curriculum. What is not as well recognized are these protracted withdrawal syndromes that can last for months or more than a year, where people can have things like panic attacks, sensitivity to light, difficulty concentrating, all sorts of neurological symptoms, which can be debilitating, can lead to inability to work, lead to relationship breakdown. And one of the issues is because of very poor recognition of this condition by doctors, a lot of people are left to fend for themselves, to rely on friends and family. It reminds me a little bit of long COVID, where people at first said, how can a short-term virus cause a long-term disability? There was fairly quick recognition for two reasons. One, it affected so many people, and two, doctors were affected, and they were seen as credible witnesses, which is maybe not the same for people taking antidepressants or other psychiatric drugs, because protracted withdrawal syndromes are possible for all classes of psychiatric drugs. To kind of tease out this issue, on the right-hand side, I'm showing a table from a study we published last year, where we asked more than 1,000 people, what symptoms did you have just before you started the drugs, the symptoms you were given the drugs for? And what symptoms did you have after you stopped the drugs? And what you can see, for example, is 3 out of 10 patients were suicidal in the weeks before they started the drugs. In other words, things were dire in their life. But 6 out of 10 people were suicidal after stopping the drugs. In other words, for 3 out of 10 people in this selected group, they were experiencing suicidality only after stopping the drugs for the first time in their lives. And that's true for every symptom we asked about. Brain zaps were very uncommon, of course, before they started the drugs, but most people had them after stopping the drugs. Impaired concentration can be part of depression, but more people had it after they stopped. And that was true for every symptom that we asked about. More people had it, many people had it after stopping that hadn't had it before they started. And I haven't shown it here, but the symptoms were also much more severe after stopping than before starting. In other words, this is a distinct syndrome where people are getting symptoms that they hadn't had before or that are much more severe. Because of this research and others, there has been quite a lot of progress in the UK. So although for 2 decades, the NICE guidelines that tell doctors what to do, give them evidence-based guidance in the UK, have described, like in Australia, symptoms as brief and mild or lasting a week or two. This has been updated in the last now 6 years. 6 years ago, the Royal College of Psychiatrists actually went on national TV to tell the public that There can be severe and long-lasting withdrawal symptoms from antidepressants. NICE updated its guidance a couple of years later to talk about months-long symptoms and severe symptoms. In Australia, there has been minimal updates to therapeutic guidelines, although I see as of this morning that your health pathways has been updated more in line with what is the latest guidance in the UK, which is great to see. If that's the problem, I want to talk a bit about how to minimize withdrawal symptoms by safely tapering. So I'll just talk briefly about why would you want to stop antidepressants in the first place. There are lots of reasons why people may no longer need antidepressants. For most patients in primary care, they are prescribed an antidepressant in the context of a stressor. Divorce, job loss, physical health problem, death in the family, with relapse unlikely. Most people do not have severe recurrent conditions and don't need ongoing medication. People may have found alternative coping skills. We know that for most people, antidepressants are not effective. The most optimistic assessment is that you need to treat 7 people to have 1 person respond to antidepressant above placebo. So that means a lot of people they are not effective for. For some people they are effective for, the effects will wear off over time because of tolerance. And we know that up to half of people are on antidepressants for longer than guidelines recommend. That's actually studies are 10 years old. It's probably a larger proportion of people these days. In stopping medications, you can reduce a lot of side effects that can impair people's quality of life in a significant way. So treatment emergent sexual side effects occur for at least 50% of people taking antidepressants. The TGA put out a warning last year that for some people that stop antidepressants, they will not get back their sexual function, or it may take years for it to come back. It's a condition called post-SSRI sexual dysfunction, or PSSD. Most people on the drugs report emotional numbing. Come back to that. It's the main reason people come to my clinic in London to come off their antidepressants. We know that antidepressants cause fatigue, impaired memory, and impaired concentration. You can see that in healthy volunteers given the drugs, so it's not just depression. They also cause insomnia, and there's a small but growing literature that shows that long-term use of antidepressants can lead to worsened anxiety or depression, something called tardive dysphoria. And although in short-term studies weight gain wasn't prominent, in longer-term studies, SSRIs and SNRIs contribute to significant weight gain for a portion of patients. So I want to talk about one of the main barriers to people stopping antidepressants, even when they're no longer indicated, is a belief that antidepressants correct a chemical imbalance. Many patients have been told that taking antidepressants for depression is like taking insulin for diabetes. But that's not an accurate analogy. We know that most patients in Australia believe that depression is caused by a chemical imbalance. We know that if they believe that, they're less likely to stop their drugs. You may have seen research a couple of years ago that looked at all the research in healthy volunteers versus depressed people. Is there evidence of low serotonin? Finding that there's not. Most psychiatrists, including the Royal College in Australia, no longer say that depression is caused by low serotonin. That was an old hypothesis. It hasn't borne out with more research. There are other explanations for how antidepressants work, different biological theories. Most of them come from animal studies or cell studies. There is a very plausible way for how antidepressants work that I think, until proven otherwise, is the way that drugs work, which is most people on these drugs report feeling emotionally numbed. That is, their range of emotions from positive to negative is restricted into the middle. If you have very severe anxiety or depression, having the volume turned down from a 10 to a 3 can be a relief. But it also affects positive emotions. It can affect relationships, a sense of self, interest. It's the number one reason people come to my clinic, like I said. I think it's a very different explanation to be told that these drugs numb emotions compared to that they rectify an underlying chemical imbalance. I think that's something that needs to be addressed directly with patients, both when they're starting the drugs and when they are considering stopping them. For older people, there are all sorts of probable health consequences. people on antidepressants have a higher risk of strokes, developing obesity, falls, cardiovascular disease, developing osteoporosis, cataracts, and even dying early. And there's a debate to what degree this is caused by the depression and what degree it's caused by medications. But for at least some of these conditions, there's no plausible connection to depression, osteoporosis, cataracts, and it's been attributed to the drugs directly. There are particular issues for women of fertile age, where most antidepressants increase the risk of fetal abnormalities by 2 to 3-fold from a low base rate. For older patients, polypharmacy is a bigger issue. So for the rest of the talk, I just want to talk about how to safely stop antidepressants. I'm going to focus on the Royal College of Psychiatrists guidance that was published a few years ago that recommends a few broad principles for how to come off antidepressants. They recommend reducing the dose over months or years for people that have been on the drugs for months or longer. They suggest going down to very small doses, less than 1 milligram, before stopping for some patients. And they recommend going down in smaller and smaller size reductions, and that the rate of reduction should be adjusted to the rate that the individual can tolerate. Some of that might sound quite unfamiliar, and I'll try to make sense of where it comes from. So we published a paper in the Lancet Psychiatry a few years ago where we looked at the effect of antidepressants on the brain. And this is taking the example of citalopram, and the y-axis is actually blockade of the serotonin transporter, but you can think about it just as effect on the brain. And the main point is, from this PET data, that it's not a straight line relationship. Going from 20 milligrams to 40 milligrams doesn't double the effect on the brain. In fact, it's only a very small change. And even a tiny dose, like 2 milligrams, which you might think of as homeopathic, actually has about half the effect of 60 milligrams, much bigger than you would think. And the reason for this is something called the law of mass action, which basically says when there's not much drug in the system, all the receptors for the drug are open for business, and every milligram of drug has a big effect. And once receptors get more and more blocked up, every extra milligram of drug has less and less incremental effect, a bit like the game of musical chairs. Easy to find a chair at the beginning and much harder at the end. And so you get this law of diminishing returns, and this shape is called a hyperbola. And that allows us to understand what happens when people come off their drugs in the way that most doctors recommend, which would be something like go from 20 citalopram to 10 by halving the tablet, perhaps, going down to half a tablet every second day to get 5 milligrams and then stopping. It's very simple to do that with existing tablets, but it's very hard on the patient's brain, because what is happening is when you go from 20 to 10, there's a change in effect on the brain. Some people find that very unpleasant. Some people can tolerate it. Going from 10 to 5 causes a larger change in effect on the brain, which makes it more severe. And going from 5 to 0 is like jumping off a cliff. It actually has 20 times the effect of going from 20 to 15 milligrams. And this is exactly what patients report. The first few milligrams are the easiest to stop, the last are the hardest. And when clinicians are not aware of this relationship, they can believe that people need the drugs, that they've relapsed, that they need to go back on the drugs. So what makes more sense is not reducing drugs by an even amount of dose, but by even amounts of effect on the brain. So I've drawn 4 horizontal lines on the y-axis, which corresponds to smaller and smaller sized reductions of dose, with this final dose before stopping a very tiny dose, so that the reduction from this dose to 0 doesn't cause a larger change in effect on the brain as the previous reductions. And because this shape is a hyperbola, this has been called hyperbolic tapering. You can explain this to people more simply by talking about proportional reduction. So for example, halving your dose every month, 20, 10, 5, 2.5, 1 1/4, 0.6, produces roughly even changes of effect on the brain. Some patients can't tolerate that, and they put in intermediate steps. So they might go down as slowly as 10% of the most recent dose every month. And if you remember, that was the rate that people on peer support websites had worked out through trial and error. And I think it's no coincidence that tens of thousands of people have come to the same solution that matches exactly what neuroimaging of these drugs shows in terms of their effect on the brain. And just to make this point, what I've shown you for citalopram is true for every antidepressant on the market. The red line is the smallest available tablet or capsule. And you can see that for the smallest available capsule of venlafaxine, 37.5, it actually has 95% of the effect of 300 milligrams. 20 milligrams of fluoxetine has 90% the effect of 60 milligrams. 50 of sertraline has 90% the effect of 200. 20 of paroxetine has 90% the effect of 60 milligrams. So patients are often told, you're on a very small dose, you can just stop your drug or stop it from half your dose. That's not true for any antidepressant in Australia. The brain doesn't care the size of the tablet or capsule. It only cares about the effect on receptors. So the smallest available tablet or capsule of any antidepressant in Australia is always a big dose, which is why people have so much trouble coming off them. They're being pushed off this cliff that people cannot see. Very briefly, there are now studies showing that people who were unable to come off their antidepressants with the normal halving and halving are able to come off when they are given a gradual hyperbolic taper over months or longer, and their withdrawal symptoms go from being very severe with these quick reductions to being very mild when they're given this slower reduction. The Royal College suggests the rate should be adjusted to the individual. I'll show you some risk factors in a second, but basically if things get difficult, you need to pause, go back a step, and then go down more slowly. And the Royal College now recommends what was on those peer support websites at one point. They give examples of reductions going down to very small doses. This is what I would consider a slightly faster reduction for someone who'd been on the drugs for a year or two. Here's an example of an even slower reduction for a drug like paroxetine, which can take people a couple of years to come off, going down using a liquid because the withdrawal effects from this drug can be so difficult, like for venlafaxine or duloxetine. The NICE guidelines now in the UK also recommend this to doctors, these proportional reductions using liquids over months or longer at a rate the patient can tolerate. The question always comes up, how do you make up these doses? You can start with tablet cutters, but that won't get you down low enough for many of the drugs. Liquid preparations are helpful. Unfortunately, in Australia, the only drug that comes as a liquid is escitalopram or Lexapro, which is very useful. Mirtazapine comes as an orally dissolving tablet that can be put in a glass of water and turned into a liquid. You can get compounding pharmacies to make up tablets, capsules, or liquids, although, of course, there's a financial barrier to many people. These drugs are not supplied by the health system yet, but I hope that they will be. Skipping doses is not a great idea for most drugs because the half-life of most antidepressants is less than 24 hours. Giving it every second day or every third day causes wildly changing levels in people's blood, which can cause severe withdrawal effects. The exception to that is fluoxetine, which does have a longer half-life. Except one note of caution for fluoxetine, it's often described as self-tapering, like you can just stop it. But actually, although it does have a longer half-life, it doesn't leave the body slow enough to avoid withdrawal effects. And so it should also be tapered carefully like other antidepressants. There are also off-label options. So there's all sorts of guidance from the NHS, I'm sure the same in Australia, for people that can't swallow tablets, to explain how to crush up tablets, mix it with water to make a suspension. You can use a syringe to make smaller doses. You can open up capsules of drugs like venlafaxine or duloxetine and count or weigh beads, put them back in the capsule and reduce your dose in that way. And one thing that we're also working on is trying to get manufacturers in Australia to make more liquids so that they're more easily available. But there are these off-label options which we use in our clinic when we don't have any other better options. So everything that I've talked about is in this handbook, the Maudsley Deprescribing Guidelines. It outlines when and who to stop antidepressants, benzodiazepines, gabapentinoids and Z drugs in, how to recognize withdrawal effects from these drugs, how to distinguish withdrawal from relapse, and probably the most useful part is specific examples on how to take someone off each antidepressant or benzo with a fast, moderate, or slow taper, how to choose one for an individual based on the risk factors, and how to adjust it based on their symptoms. And it covers all the different formulations of drugs to be used in Australia, as well as off-label options. So just very quickly, it'll give you a set of risk factors for a patient, how long they've been on the drug, which antidepressant they're on, their dosage, their past experience, work out their risk, and then start them on a taper, either slower or faster, depending on their risk factors. It gives you step-by-step doses, when to use tablets, when to switch to liquids, when to use off-label options. That would be a faster version, and a slower version for people that have difficulties. And then just to quickly say, everything that I've just said for antidepressants is also true for all other psychiatric drugs, to reduce by these smaller and smaller amounts in this hyperbolic way down to very low doses, again, because the same curves also apply to diazepam and to drugs like pregabalin and gabapentin, and all of those are covered in the handbook. And it's also true for things like quetiapine, any other psychiatric drug used in primary care, stimulants and opioids. So that's a QR code that's will give you free access to the e-version of this handbook. It's endorsed by the Australian College of General Practice, and they've helped us to make this available for free. It's a bit finicky. I think you've got to click through a couple of ads, I'm sorry, through the program that supplies it. But that will give you access. I think it normally costs $80, so it's save you a bit of money, and it'll give you access to guidelines for all those different drug classes. I'll stop there. I'm happy to take any questions.
Thanks very much, Mark. That was really quite frightening, actually. I've been a GP for over 40 years, and the changes that I've seen in that time, from when I started in practice, there were no selective serotonin reuptake inhibitors. You could only prescribe tricyclic antidepressants for depression. And so I was there when the first fluoxetine or Prozac was brought out, and everybody thought it was this miracle drug, and as you know, it became completely overused and a problem in itself. But this is really really quite insightful. Just before I go to the questions, I wanted to say one of the things that I think we as GPs can do is giving the patients the validation that we understand how hard it is to come off the medications, because those people that you had in that video were they felt couldn't trust their doctors. They felt nobody was listening to them. And I think if one of the things we can do is actually saying to them, yes, I'm hearing you, this is going to be hard, this is how we're going to do this together, I think you'll have a better result than otherwise. But anyway, let's get to the questions. So, and I'm actually Sandy, I can't read them completely. Not sure.
Hi, Terry.
Out, Terry?
Oh, I'm sort of I can't actually read the whole question. So how do I press on it?
Would you like me to read them out? Yeah, I can see them.
I need to, because I don't know why it's only showing me half the question.
Oh, well, the first one is, does the downregulation of serotonin receptors explain why some people feel like their antidepressant doesn't work after a few years and request a change in antidepressant?
So, I mean, yes. So exactly. Downregulation means the body is getting used to the drug. I mean, you know how when people start a drug, they often have side effects, and the side effects wear off over time. People think that's a good thing, but it's a sign that your body's getting used to the drug. It's actually a sign of tolerance. And it's why you get withdrawal effects later on. So in fact, once you've been on a drug for a few weeks, you're already set up to get withdrawal effects. So yes, over years, the effect of the drug wears off, just like benzodiazepines or opioids. That's been very much minimized by the manufacturers. They say tolerance doesn't occur for our drugs. That's impossible. It occurs for any drug that causes withdrawal effects. That's part of also why they wanted to use this phrase discontinuation symptoms. They've obscured these issues. But yes, the answer is that is exactly why that tolerance occurs.
Mm, mm. And the second question was actually from me, and I hope it's not an embarrassing question, but would it be feasible, so the only liquid preparation, proprietary preparation is escitalopram, as you said.
Yeah.
Is there a role for changing people over to escitalopram before you taper?
Yeah, so I get that question a bit. I would say maybe, and I'll tell you why I say maybe. I mean, I think maybe prescribing escitalopram at the beginning might be worthwhile because of it's got an off ramp where the other drugs don't have it. The issue with switching is sometimes switching is not as smooth as the textbooks say. So switching kind of comes from benzodiazepines, where switching is normally okay because benzodiazepines are extremely similar to one another as a class. Although SSRIs sound like they're all from the same, they're all very similar, they're not as similar as they sound. So sometimes people who switch from sertraline to escitalopram get all sorts of withdrawal symptoms because some of the receptors that they target are not covered by escitalopram. So if you did switch across, I would do it a bit carefully. I wouldn't do it in one go, might break it into 4 steps, reduce your dose by a quarter, take a quarter of escitalopram, and so then half and half, and a quarter and 3/4, just to make sure that nothing goes wrong. Because I have seen, the textbooks say it's all a dream, just switch them over in a few days. I've often seen people get into trouble like that. So if you tried it, and I can see the rationale, I would do it carefully.
So interesting, thank you. And I think Terry, hang on, I think another question's just come through.
There's a few questions here, but again, I can't read the end. So there's from Liling Liao. How are hyperbolic decreases achievable in the practical sense? Is it actually, and then I can't see how to get the rest of that.
If you double click on it, I can see, is it actually possible for the antidepressant to be compounded and more complicated by the fact some areas are in capsules, some are in capsules only. So that's a great question. It's one of the practical barriers. I try to give you a very quick overview of how you can do it. You can compound all antidepressants into something smaller. They either do it by getting the powder, putting it in capsules, dissolving it in different suspending vehicles. So it is possible to be done. The beads, drugs that contain beaded drugs like duloxetine and venlafaxine are a bit more complicated. Venlafaxine can be turned into a liquid. Duloxetine needs to be kept in beads. What compounding pharmacists do is they weigh or count beads and re-encapsulate them for you. So capsules doesn't mean you can't do it. There's a lot of off-label options. A lot of patients will crush up tablets and mix them in water or open up capsules to count beads. Those all have minor issues with inaccuracy. But when that's the only option and the alternative is to stay on the drug, I think it's a very reasonable route to take, and I do that in my clinic for lots of patients.
Thanks. I've worked out the questions now. So this is from Michelle, which is quite interesting. Is why do you think that this has not been widely recognised in Australia, and is there some controversy or disagreement?
Yeah. So I sort of tried to outline why there has been this sort of mismatch between what guidelines say and what patients experience. Originally it came down to the drug companies did very short-term studies, 8-week studies, 12-week studies. They found mild symptoms. So that was what has been in the guidelines in education for decades now. And I sort of feel that doctors often pay more attention to guidelines than patients. And so although patients have been complaining about this for many years, and there have been numerous successful lawsuits about these issues in America, almost every single drug manufacturer for antidepressants has been successfully sued for withdrawal effects. It always comes with a non-disclosure agreement, so it's never very public. But if you look it up, you can find the lawsuits. I think that there are a lot of academic psychiatrists who have been paid by industry to promote these lines as well. So there's a very big issue with psychiatrists and academics becoming the paid spokespeople for these products. And so for years, a lot of prominent voices in the media have been saying withdrawal effects are minor, the drugs are easy to stop, and I think they have a very big influence on guidelines, on public sentiment, and I think that's part of why there's such a mismatch between what happens in reality and what the guidelines say.
Thanks. The next question is from Christine Unterberger. How is the outcome in your experience for severe protracted withdrawal damage? What are their observations regarding recovery versus persisting damage to the nervous system?
So it's a really good question. It's hugely understudied. It's often ignored, this issue. I'm glad he used the word damage, because I think in some ways the word withdrawal, although it's commonly used, is a bit misleading. When people have trouble for a year or two after stopping their antidepressant, those people are often not helped by restarting the drug. I sort of mentioned that very briefly. If you go away on a holiday for a few days, forget your drug, get withdrawal, come back, take your drug, withdrawal goes away. That happens all the time. Once you develop these protracted withdrawal states, it's not as reversible with restarting the drug. And so it does make me think this is something like an injury to the nervous system or some sort of damage. It often improves over months and sometimes years. So these people are very, very badly affected by it. I think there is some resilience in the nervous system, better for younger people than older people, but you do see very severe levels of disability in these people, and they have symptoms that they've never had before starting the drugs. So I think this is, a bit of a brewing scandal, how many people are affected long-term after being on these drugs.
Thanks. Is vortioxetine any different in regards to tapering, as the manufacturer keeps promoting it as a drug that does not require it?
Yeah, I think this is the same story repeated. Vortioxetine is basically an SSRI with a couple of extra whistles and bells on the side. It has all the same issues in coming off. It has a slightly longer half-life than other antidepressants, but not long enough to eliminate withdrawal. I see people having trouble coming off vortioxetine all the time. It's a newer drug, and there's sort of a game of cat and mouse, where it takes independent researchers a couple of decades to catch up with the studies to show that what the manufacturer said when they released the drug is not quite true. They've caught up with most of the SSRIs, and vortioxetine, the studies haven't been done yet, but the answer is it's exactly the same.
This is from Gordon Lau. This topic came up over lunch, and I was trying to raise this with our registrars. However, I was dismissed by a senior doctor in the lunchroom.
Yeah.
How do we help to support a change in our practice?
So I've got to say that's been, I've now given this lecture to about 300 groups of doctors, and I noticed that there's a very big differentiator in the response. Older people that have less hair on top of their head than me, which is a smaller and smaller group these days, say, I don't see this, I don't have any problem with people coming off their drugs. And younger people say, which drugs can I open up to get beads? Which ones need liquids? I see this all the time. And I think it's a question of education. If you've spent 30 years being told there's no withdrawal symptoms, these drugs are fine, when people stop, they relapse, they must need the drugs, it's very hard to unsee what you've been taught to see. Whereas I think younger people are a bit more open to this. So I think this is becoming more and more well known in Australia. There's been media attention. It's becoming a part of medical schools. I'm asked to lecture to a lot of different groups of psychiatrists and GPs. I think you might want to wait till the senior doctor is out of the lunchroom and then start teaching the registrars, because in the UK, it's become a bit of a legal issue. Patients have started taking to doctors to court because of some people lose their jobs because of withdrawal effects. So it has a very big effect on patients. So I think it'll start to be more of a legal risk. So I think it's an important topic. GPs can help a lot of patients by learning these things. So I think we've just got to keep on raising awareness of these issues.
Mark, on the opposite side of it, though, to say, are we going to be scaring people, doctors, from ever prescribing antidepressants at all? And so how would you, because I certainly over the years, I have had patients I've had fantastic results from going on to an antidepressant. I can remember one man that I saw, and I put him onto fluoxetine. It was probably in the 90s. And he came back and said to me, months later, if only he'd have been on this medication, he thinks he would still be married to his wife. But I think he was somebody who did have a major depressive disorder. There was a strong genetic vulnerability for him. So how do we teach our doctors, our registrars now, how to make that decision?
So it's another 45-minute lecture that I give. So to compress that into 45 seconds, 1 in 6 of the public is now on an antidepressant. It's doubling every 10 years. Most of them are on the drugs for much longer than they need to be. So, we have a huge issue with overprescribing. It would be very unusual if learning about a very serious risk of a drug didn't reduce prescribing. So I think that's the natural response would be, you're always weighing up the benefits and harms. If the harms are much greater than we have been led to believe, then of course there must be a rebalancing of prescribing. I think doctors need to be more discerning in who they prescribe to, need to set people up for shorter prescriptions. I think that's a natural consequence of learning about a new harm. The question of, is there a group of people for whom these drugs are useful? It's a very contentious area. There probably is a small group that benefits. It might be because of emotional numbing. That might be very useful for some people. But I do think that the main issue is informed consent. People need to know, how effective the drugs are. There are quite minimal differences between placebo and antidepressant, even for severe depression. I've talked about the side effects. I've talked about people need to know that withdrawal effects can be severe and long-lasting. Some people may not be able to get off their drugs when they want to, and alternatives. In the UK, NICE says that there are 19 equally effective and cost-effective treatments for depression that don't involve medications, including various forms of therapy, mindfulness, exercise, and actually the single most effective treatment for severe depression is problem-solving therapy. So I think we also need to take a step back and recognize that most people are depressed because of the issues in their lives, relationships, finances, health issues. And I think we have greatly overly medicalized helping people in distress. It's very hard that I feel very bad for GPs where all these issues are thrown at their feet and they're only really set up to see people for 10 minutes. I do think there needs to be a bit of a restructuring in the way that we deal with people's emotional problems, because if we medicalize everything, we know that by the age of 45, 9 out of 10 people will have a mental health problem. So if we medicate everybody, it'll soon be most of society that is medicated. So I do think there needs to be a little bit of a recalibration of how we respond to people's emotional problems.
Thanks. I'll go to Michelle's next question. How should we manage people who have had their medication stopped abruptly in hospital?
Yeah. So it's a bit of a nightmare. The answer is, if you get in quickly, you can restart their medication and avoid any trouble. For some people, the word damage or injury was used earlier. I think for some people, stopping the drug quickly leads to something neurotoxic. It leads to some kind of injury or damage that's very hard to sort of put the toothpaste back in the tube. So I would try to restart the drugs as soon as possible, hopefully, a few days after they leave hospital, but it can leave people with long-lasting issues after stopping. So I would, try to get the inpatient team to pay attention to these issues, and then and then rectify things as quickly as possible after people come out and restart the drugs.
Let's just go. Oh, somebody, I think they want you to show the QR code again.
So what I've done is I've gone to the chat and I've stuck in a link to click on. It's Glose. If you click on it, it'll take you to redeem the book, which is less finicky than the QR code. Although I might as well share that if they've asked for it as well. Just if people want to use the more tech cool way to do it.
trying to see if I've missed any questions. What is this one here? What is your opinion and experience on daridorexant regarding addictive reaction?
So it's hard to keep up with all these new drugs as they come out. That's a new sleeping tablet. It's also been approved in the UK. I can't remember the mode of action of it, but I've sort of in studying this now for 15 years, I think that there's no such thing as a free lunch. Basically, if a drug makes you feel relaxed or sleepy or calm, it's going to cause adaptation. You're going to get used to the drug. It's going to wear off over time, tolerance, and when you stop it, you're going to get withdrawal effects. That is true for alcohol, benzodiazepines, antidepressants, gabapentinoids, opioids. I don't think there's a drug that gives people a sleep or anxiolysis without a cost down the road. So I don't know the exact details of it, but that would be my first thought about it.
And then I think a question here from Gina, is the medical ketogenic diet a possible treatment for protracted withdrawal syndromes and neurological damage?
The keto people in America have sort of said keto is useful for almost anything. I do think it can make people feel calmer. I've never seen anyone, I've seen a lot of people try it with protracted withdrawal. I've never seen anyone say it's completely changed the course of their symptoms. If it makes people feel a bit more calm, it's probably helpful. I'm not sure that it's going to help them sort of fix their nervous system, but it seems like a harmless thing to try. So I guess I would be open-minded, but slightly skeptical.
And then this is the last question I've got here. And how long should a patient stay on an antidepressant if they have had a good benefit after an episode?
Okay, it's another 10-minute lecture, but I'll give you the 30-second because I know it's getting late in Australia there, eating into your evenings. The guidelines in Australia, therapeutic guidelines, say that for an episode of depression, patients should stay on their drugs for 6 to 12 months. And for people with recurrent disorders, they should stay on it for 2 years or longer. I don't think that is accurate advice, because the studies that those are based on are studies where people on the drugs are randomized either. Maybe I'll share a slide just because it'll make this a lot easier to explain. Just going to, excuse me, get a different PowerPoint up for 1 second. So hopefully you can see this slide for a minute. These are the studies that the guidelines are based on. They take people who have improved on antidepressants and they randomize them to either stop their drug or continue their drug. And they monitor them for 6 to 12 months afterwards with different depression scales looking for relapse. And when you put all these studies together, 40% of people relapse if they come off the drug, and only about 20% do if they stay on the drug. And that's why people are recommended to continue on their drugs. The problem with these studies, just go to the main problem, is in these studies, the drugs are stopped in 1 day, or the average is 5 days. Withdrawal effects will register on all these depression scales because they include questions about anxiety and sleep and mood. And so this relapse rate is going to be inflated by misclassification of withdrawal effects as relapse. And so the ability of antidepressants to prevent relapse is not as great as these studies say. And some researchers have even suggested that the entire difference is explained by withdrawal effects. To use a little bit of a glib analogy, if you took people who smoked and divided them into either stopping smoking or continue smoking, and you measured anxiety and irritability, you would conclude that people should continue smoking to prevent becoming anxious again. If you ignore withdrawal effects. Now, cigarettes and antidepressants are not the same sort of drug. The point is that if you ignore withdrawal effects, you can come to some quite perverse conclusions about the ability of a drug to prevent relapse. So I think the studies that suggest to keep people on drugs is not robust, or very methodologically problematic. The longer you take a drug, the more likely you are to get withdrawal effects from it. So I would say the sooner you stop the drug, the better, if they've experienced a benefit. So I think if people have experienced a benefit of the drug, then as soon as things are stable, that's when I would start taking them off it, so they don't get into this trap of being stuck on the drugs because withdrawal symptoms are too severe.
Thanks, Mark. I think that's all the questions. Was there something else that we're going to do?
Yes, we are. Sandra's just going to do a quick presentation now of health pathways.
And Jenny, I think we'll skip the slides because it's getting very late. I have put a link. I've put a link in the chat with if you click on that link, that will get you through to how to jump onto health pathways for both Hunter New England and Central Coast, because we're covering both regions tonight. The simplest way to get a personalised login is to use those generic login details I've put in the chat. So use those, and then a yellow button will pop up, and then click on that. 2 reasons you need to do that is personalised logins are now going to be the only way to access health pathways after the 1st of July. Those generic login details will cease to be able to be used. And then the benefits of having personalised login is that you can track your usage on health pathways and use it as part of your CPD reporting. And also there's a really great AI search function you can use now that makes it much easier to find the information. So please do that. But I'm just going to quickly share my screen and hope this works.
Just hold on 1 second.
I think it
might. Yes, it has.
Oh, there you go. Clever. So on all of the relevant health pathways, so for example, medications for moderate or severe depression in adults, you will find in the clinical editor's note a link both to the Maudsley Deprescribing guidelines, but you've all got a QR code now to access that. But these release resources, and hopefully you'll see this. No, you won't see this. I need to share something different to show you this. And I'd be interested to know, Mark, I'm hoping that this is okay that we've linked to this, because this has got all the, when you click on that link, it's got all the tapering plans for all the antidepressants, the slow and the fast tapering plans. And I'll just show you one of them. So for example, this is the sertraline one. It's got, this is the faster taper. And how to do it and how to make up the liquid suspensions, which will then negate the need to go to a compounding pharmacy. Is that correct, Mark?
Yeah. So one of 2 options: you do off-label or go to compounding. Some people still prefer compounding, but yes, got 2 options.
Yeah. So I would encourage you to go to that that clinical editor's note and find that information up there. So you just click on release resources and all those tapering guidelines will come down. It's also been incorporated here in the drop-down box on stopping medication, and also down under the for health professional information. And what I'll do tomorrow when this webinar gets uploaded is I will upload the webinar in that for health professional resource as well. So after the webinar, you'll have access to all of that via the Health Pathways site. If you have any trouble logging on, particularly with the personalised logins, please just drop us a line via the PHN or via any of the send feedback buttons. Thank you so much, Mark. That was an amazing presentation. I don't think I'm going to be able to get to sleep tonight. It was just eye-opening and amazing.
Yeah,
I agree. Yeah.
Thank you very much, Terry, as well, for facilitating the questions. And Mark, thank you so much. As I said earlier, this copy of this webinar, the recording will be available in our library from tomorrow. Well, good night, everybody, and thank you for coming. And this webinar was accredited with RACGP and ACRM, and I will upload your CPD hours over the next week. Thank you. Good night.
Thanks very much. Thanks a lot, Mark. Nice to have met you.
Likewise.
Yeah,
thanks.
thank you.
Thanks for arranging it. Thanks, everyone.